Hello, my name is Tabitha Taylor. I am a certified medical laboratory technician with ASCP. I am also a senior at Winston-Salem State University. I have been a medical laboratory technician for 11 years. Currently, I am working as a lead tech on first shift and as a generalist at Novant Matthews Medical Center in Matthews, North Carolina. Today, I am presenting my proposal, but I am also attaching my full proposal along with this video if you would like to refer back to it. Okay, let's get started. The title of my proposal is IPF Percentage, Benefits and Efficiency of Treatments for Neonatal Thrombocytopenia. Okay, first, I would like to talk a little bit about neonatal thrombocytopenia. Neonatal thrombocytopenia is the second leading hematological cause in neonates admitted to the neonatal intensive care unit. It is estimated around 25% of all neonates admitted to the neonatal ICU is due to thrombocytopenia. There is also a correlation between premature babies and underlying thrombocytopenia conditions. Thrombocytopenia in neonates is defined as a platelet count less than 150,000, or what we're going to talk about today, a severe platelet count of less than 50,000. The sources of neonatal thrombocytopenia can be numerous, but doctors need to investigate the origin of the thrombocytopenia in these neonates to give swift treatment to avoid hemorrhaging or even worse, demise in some cases. Today, the gold standard for investigating the origin for thrombocytopenia is the bone marrow aspirate. The bone marrow aspirate is very invasive and time consuming because after it is collected, it is sent to the flow cytometry department. So the turnaround times on these results can take hours or even days. This is also a very costly procedure that is for the patient and the patient's family. So my proposal is to introduce a new clinical parameter that comes standard now on a hematology analyzer that can be resulted out along with the patient's complete blood count. This is called the Sysmex XN2100. These are the new advanced instruments for hematology, and on these instruments come standard new parameters, which is what I'm going to be talking about today, the immature platelet fraction. This instrument uses fluorescent technology to count reticulated platelets or immature platelets and gives them out as an absolute count or a fraction. How this will help is in an increased IPF, as you can see here with this graph, if a patient has a low platelet count but a high IPF, that means that their bone marrow is producing platelets fine, but it somehow the patient has a destruction disorder. So you would know that the bone marrow is producing megakaryocytes, but they have a different condition. As you see here, if you have a normal platelet count, the platelet count shows up in the normal platelet field. There is not any immature platelets. But if the patient has a low platelet count and a low immature platelet fraction, which is here, then that is consistent with a bone marrow production disorder or a bone marrow failure. Using these clinical parameters can help the physician decide which avenue of treatment is best for the neonate and can get these results quickly and timely and are less costly. My proposal is to do a clinical comparative study that will be performed over a year long. Neonates that are eligible to participate should exhibit moderate to severe thrombocytopenia, which is less than 50,000 platelet count. We will also use a group of 40 to 60 neonates over the course of a year that is admitted to the ICU. And we will also compare these to 40 neonates that have unremarkable platelet problems or normal platelet counts as a control group. We would also get all written and signed permission from the neonate's family for this comparative study. This step is crucial to ensure the quality and safety for all patients. What we would do is we would evaluate the patient's platelet count, and if they are moderate to severe, we would collect a whole blood sample and run it on the Sysmex XN to get the immature platelet fraction. This would also test not only the patient's platelet count, the immature platelet fraction, but also the MPV, or the mean platelet volume. And this will be compared to if the physicians do collect a bone marrow aspirate. Once this data has been collected and reviewed, we would like to show that this instrument can not only be quick turnaround time, it's less invasive, so you don't have to worry about such a invasive procedure on the patient, especially for neonates, for a bone marrow aspirate. And the doctors can get their results quicker. They can treat the patient, which is first and foremost quicker than having to wait hours or days, especially if the neonate is suffering, so to get quick treatment for that patient. Conclusion, we would hope that with this proposal it would show the benefits of not only with prompt treatment, but that these newborns were treated positively, and there was positive correlations between the IPF percentage versus the